Hello. I'm sorry I couldn't be with you today, but I'm Wendy Chung, and I'm going to speak with you about our studies related to rare diseases, early diagnosis, and newborn screening in a study that we call Guardian, Genomic Uniform Screening Against Rare Diseases in All Newborns. Let me start by saying that rare diseases are individually rare but collectively common. There are over 7,000 such conditions and counting, and in children in particular, we see these with great frequency, in part because many of these children historically have not lived to be adults. The frequency, as I said, may be something like 1 in 5,000, 1 in 20,000, even 1 in a million. But when you put them all together, we see them very frequently in many, many children who are born. As I've been thinking this over time, I've been trying to think about things that are common that will help all rare diseases. So, common infrastructure that will help us with rapid diagnosis, easy diagnosis, so that we leave no one behind. And more importantly, getting to the supports and the treatments that will sustain everyone to have their best possible health ahead of them. This started for me actually thinking about phenylketonuria when I was working with Seymour Kaufman at the National Institutes of Health about 35 years ago. And then most recently for me became feasible to think about in the modern era of newborn screening as we'd been working on a condition called spinal muscular atrophy, or SMA. This condition used to be, past tense, the most common genetic cause of death for children less than 2 years of age. It's actually present in individuals from around the world, regardless of ancestry, in about 1 in 10,000 births. And through the natural history studies we had done as part of the Pediatric Neuromuscular Research Network, we knew that this was a degenerative condition with loss of the motor neurons. And once those motor neurons were lost, it was impossible to go back uphill and regain function. Within this, we also knew the natural history in terms of when children were being diagnosed. And as you can see, the most severe infants with type 1 SMA, who usually did not reach their first birthday, oftentimes were not diagnosed until about 6 months of age. It just took time for parents to recognize symptoms, pediatricians to make referrals, genetic testing to be performed. All of this, oftentimes, like I said, taking several months. And unfortunately, we knew from the natural history that by that time already much damage had already been done that was irreversible. So, as we were thinking about clinical trials that would be available initially with an oligonucleotide called nusinersen, I began to be concerned that we would not have individuals at a stage of their disease that would be amenable to treatment. That is, that even if the ASO would work, that we would not have identified those children early enough to see the impact. Or if we would, it would take many, many more children to demonstrate that from a power point of view. So I put forth the suggestion that we do newborn screening for SMA because genetically it was relatively straightforward. Most children had a common exon 7 deletion of SMN1, which we could target genotypically based on DNA extraction from the dried blood spot for newborn screening and then performing a targeted assay. In doing so and timing it to be coincident with when the clinical trial would have a possible treatment available, it was not simply diagnosis, but diagnosis with the possible entry into a clinical trial. And for this, the alternative, unfortunately, was likely death or permanent ventilatory support because we knew the natural history and we had no other alternatives. So at this time, again, coincidentally, with the clinical trial for the ASO being available in New York State, we started a consented research study to screen for SMA. In doing that, we had very high uptake and very strong feasibility. 93% of parents decided they did want to do this for their child. We proved that we could do this within a few days of life and be able to do this in parallel with regular newborn screening and report it out at the same time. And this was the first of the children that we diagnosed through that newborn screening program who would have had type 1 SMA. That is, she had 2 copies of SMN2 and the deletion of SMN1. She started by 2 weeks of life into the ASO trial. And in fact, these you can see her home videos from her steps. She's strong, reaching her major motor milestones on time, and in fact has continued to be asymptomatic and done clinically extremely well, again, because she started her therapy early. With data from her and other children like her, my Christmas present that year was FDA approval for Spinraza, and that gave us not only the data that we could do the newborn screening, but also now an FDA approved and effective treatment such that we could put forth a strong nomination to the recommended Universal Screening Panel, Secretary's Advisory Committee, to be able to nominate SMA for newborn screening public health implementation. That, in fact, was accepted, and in very rapid succession, due to support from Cure SMA, this was implemented across the United States in each one of the state-implemented programs. This has also gone, I'm proud to say, beyond the United States and around the world, and there are now 3 FDA-approved medications for SMA: nusinersen, or the oligonucleotide, a one-and-done gene therapy given IV, as well as risdiplam, an oral medication. And within this has completely changed the face of SMA, wherein now we leave no one behind. We diagnose every child. And of course, it's not just diagnosis, but it's treatment and changing the natural history of this condition. So after that success, we started talking to our families in that newborn screening study, not the ones who had SMA diagnosed in their child, but the other families. We started asking them several questions over a period of years about what else they would want their child screened for by newborn screening if they had the option. What were the parameters? What would it look like? What were their concerns? And how would we implement this? And based on this, they designed the Guardian study. Within this, the Guardian study is predicated as a consented research study where we use that same dried blood spot that we use for regular newborn screening, but now we perform whole genome sequencing, but we don't look at everything within the genome. We pre-specify the genes that we will examine for genes that are actionable, treatable, similar to the Wilson and Younger criteria we use for regular newborn screening. Similar conditions, but ones where we need to have DNA sequencing to be able to make the diagnosis. In doing this, parents understood that this was going to be more complicated than just consenting for adding one more thing to newborn screening. So they asked to start thinking about this earlier. During the 3rd trimester, when they were preparing for the delivery of their child, they were starting to think about breastfeeding, their delivery plans, and to have this within the packet of information they received. However, we realized that parents, especially early on, would have many questions and need to talk this out. So at each of the 6 hospitals where we currently perform this, we have a coordinator go to the bedside after birth to be able to explain the study, answer questions, and give parents up to 30 days after birth to make a decision. After they do decide, and if they do decide to enroll, we work with the New York State Department of Health to recycle the newborn screen dried blood spot and the residual sample to perform whole genome sequencing in a CLIA-CAP clinical laboratory for a pre-specified set of genes. And these genes, again, are things that benefit from early treatment and early intervention. Within this is a screening test, and like all screening tests, it's not perfect in the sense that there can be false positives and theoretically false negatives as well. Within the study, we believe in a whole system, so it's not simply screening, but it's also confirmation of the diagnosis and onboarding children to care. And through that whole time, through that whole process, supporting families, as this can be oftentimes an anxiety-provoking call to get a call of an abnormal result. And we want to be able to set expectations and help them manage this information. I'll get into the data in a second, but as I said, we have mostly true positives, and we're learning over time about how to reduce the false positives that we see. Parents, again, through a series of focus groups and individual educational sessions, helped define that we should focus on conditions that were either needing action or would present with symptoms for children less than 5 years of age and have a high probability of doing so. And we operationalize that to greater than 90% likelihood of symptoms or needing actionability based on the published literature for those conditions. It was interesting that parents clearly all wanted information that was led to a complete cure. There was no question about that. But there were some conditions associated with epilepsy in particular, where early recognition of the epilepsy and treatment certainly improves outcomes, but the children still might have some residual neurobehavioral issues. And parents didn't come to 100% consensus on that, so we left that as an optional module. As we did this, again as a study based in New York City, we realized that our ability to accurately interpret DNA variation across the world was not necessarily equitable. And so as we did this, we had to come to some compromise so that we wouldn't have too many false positives, but that we also wouldn't leave children behind from the ability to interact and to treat their conditions. So we ultimately decided that for dominant or X-linked conditions where we only had one variant to interpret, we would limit those variants to pathogenic or likely pathogenic variants. However, for recessive conditions that depend on two variants, we would require that one variant be pathogenic or likely pathogenic, but that second variant could be a variant of uncertain significance, leaning towards being likely pathogenic to minimize the number of false negatives we would have. So here are the data from the first 15,000 babies that we've screened for whom we have outcome data. I'll say that as of today, we've screened more than 24,000, but many of them are still in the process of gathering outcome data. So I'm presenting only the first 15,000, and this is now since we started over 3 years ago. As you can see, the majority of parents do decide that they would like to be in the study, 73%. And in the upper right, you can see that this New York City population is a majority minority. That is, it's about 33% white, but otherwise individuals from around the world. This has made it harder for us to interpret the data, but in fact, we take our time to do it, and it takes a little bit more time, but we know that we can do it accurately. As we look to see who enrolls, this is actually reflective of the communities that deliver at those hospitals. That is, that we don't seem to have bias either by type of insurance or by self-reported race or ancestry. Of individuals who participate, most do so prior to discharge from the hospital, although about 6% take a few more days, up to 30 days after birth to consent. And of course, that's fine. For most individuals, 92, 93%, they elect to do the core conditions as well as the optional group 2 conditions, but there is a little bit of difference in individuals who consent in Spanish are a little bit less likely to do the group 2 conditions. We talk to individuals who decide not to participate to better understand why. We want to make sure that we're clear in our communication and address any of the concerns as we continue to improve the study. And for the most part, individuals decline participating simply because they have faith that the regular newborn screening is sufficient, or they're not interested in participating in any sort of research. It's not specific to newborn screening, they just are not inclined to participate in research. Specifically, the number of individuals concerned that this is a genetic research study or concerns about genetic privacy or discrimination are very, very small. Those are not the main reasons for declining. Overall, currently, our positive rate overall is about 3.3%. And this number has actually decreased over time as we've been able to minimize the number of false positives. As you can see, I've divided these out by group 1 on the top and group 2 on the bottom, and the majority of our positives, as expected, are in group 1 conditions. And of the group 1 conditions, a large number are for G6PD deficiency associated with hemolytic anemia and jaundice. You will see in red individuals who are false positives. So as we do follow-up and go through to understand which results are correct or not correct with confirmatory testing, we do have false positives. But you can see as an example in the pink on the upper right that we do have some false positives that we learn about. This particular one is in the gene for cystic fibrosis or the CFTR gene. We learn to recognize those, eliminate them from the pipeline, and then we see that the false positive rate is decreased as we learn how to recognize and correctly attribute those to being normal results. I'm going to divide these up into group 1 conditions, the first group of those that are part of regular newborn screening. And My main message here is that the DNA sequencing as an orthogonal method actually enhances regular newborn screening. So these are conditions that are included within New York State's newborn screen, and no screening test is perfect. In particular, we enhance what we can do with screening for immunodeficiencies by adding the DNA sequencing. And those are incredibly important because they can be lethal due to those immunodeficiencies. Let me go through a couple examples so you'll understand what I mean. As I said, G6PD deficiency is the most common positive result we have. It's an X-linked disorder, and so, not surprisingly, most of the individuals are males. However, the frequency of the alleles is so common that we even see 31 females within the group that are positive. As you'll see on the lower left, the majority of individuals who are positive are from minority backgrounds. That is, they're Black, African American, Latina, Asian, but non-white or not of European ancestry. And we know this based on where we see this around the world, often enriched in the malaria belt. These individuals have an increased risk of neonatal jaundice or kernicterus, as well as over their lifetime can have hemolytic anemia and require transfusions, especially when they're exposed to certain things, fava beans, mothballs, certain types of antibiotics or antimalarials. So within this, it's quite important to know this actually over the life course as well as in the newborn period. As you can see, for those of you who are aficionados, the small percentage of those are those with the most severe enzyme deficiency in blue, that portion of the pie, are individuals with less than 10% enzymatic activity. And those are probably the ones where it's most important that they know about this information. And they are certainly, as we've been following up the babies, those who are most likely to have jaundice or require transfusion. This is thankfully a much less rare condition. This is a little boy that we had with severe combined immunodeficiency who had a normal newborn screen for the T cell receptor excision circle assay. That's the normal assay that we do in newborn screening to pick up SCID. His results, however, were normal and he was missed. But when we did the DNA sequencing, we saw that he had an IL-2RG mutation. After testing his parents, we understood it to be de novo. And based on the literature review, we saw that there were two other cases with individuals who had the same exact mutation, one of whom unfortunately died due to his disease, and the second had a life-threatening infection at 1 year of age, but was saved with a hematopoietic stem cell transplant. We convened a national panel of experts in inborn errors of immunodeficiency and SCID. We did some functional assays to demonstrate that this little boy, in fact, was lymphopenic and had an abnormal STAT5 activation assay. And with those data in hand, this group of subject matter experts recommended that he undergo bone marrow transplant within the first 100 days before he had any serious infection. And in fact, we did that with a haploidentical sibling donor. He is thankfully doing fine. He's even had a younger sibling and guardian who's also fine. Within this, of course, the whole goal was to be able to expand the conditions. So I'm showing you here additional conditions that aren't on regular newborn screening that we've been able to add based on using DNA sequencing as the primary method. After we see the results for this, we perform outside of the dried blood spot, but we get an additional sample to perform confirmatory testing and then onboard the appropriate children to care. So let me show you some of the examples so you can get a sense of what information we sometimes uncover. This is a little baby who's still undergoing treatment with an RB1 mutation for retinoblastoma. This is a condition in which there are tumors in the eye. They can lead to blindness, and of course, as cancer, can be lethal. So this baby had a de novo mutation, we found out after testing the parents. And with this, we brought the baby in to be able to screen, as we do under anesthesia, screen the eyes to see if there were any retinoblastomas. And in fact, at the first exam at 6 weeks of age, we identified that there were a total of 8 tumors, 5 in one eye and 3 in the other. Luckily, we were able to immediately cryoablate them, saving vision, and start chemotherapy. This child continues under surveillance and, in fact, has had new independent primary tumors, which is often the case for this particular condition, and they've again been cryoablated and vision has been preserved. So this child is still ongoing, having surveillance as well as treatment. So we'll see how things turn out, but incredibly important to make this diagnosis early and just to show you how early these tumors can grow. This is a different child who was diagnosed with mutations, two different mutations in the recessive condition for Batten disease. Batten disease is a neurodegenerative condition due to an enzyme deficiency. In this particular case, we confirmed the enzyme deficiency by doing a functional assay of the TPP1 enzymatic activity and demonstrated that clearly the level of activity was far below the normal range, 1.88, with the normal range going only down to 15. So you can see well below that normal range. Within this, thankfully, there is enzyme replacement therapy that can be administered to prevent the degeneration from the accumulation that results within the neurons. This was performed by putting an reservoir into the ventricle because we have to infuse this into the brain. That gives a way of being able to directly access the brain to do in a relatively straightforward way those enzymatic replacements. And this child continues and will need to continue for life those infusions. Thankfully, the child is tolerating this well and neurologically normal. This is a third child, again, for a condition that's not currently undergoing newborn screening, or at least was not at the time. And this child has a condition called metachromatic leukodystrophy. The parents actually had carrier screening during the pregnancy, and they knew they were ARSA mutation carriers, but elected not to have prenatal testing. After the baby was born, in their newborn screening, we didn't know about the parents being carriers, but we identified that the baby was homozygous for mutations that were known to be pathogenic. After that, we went back to the parents to confirm the level of enzymatic activity and again demonstrated that the aryl sulfatase A level of activity was only 21 nanomoles per hour per milligram, with the reference range being greater than 62. So the baby clearly had the deficiency. There is now, just recently, an FDA-approved treatment for MLD, and this child is currently undergoing gene therapy for this condition, which hopefully will provide a cure. Let me finish up this portion of the talk by talking about a more common condition. This is long QT syndrome, or an arrhythmia that can be associated with sudden cardiac death. Based on the Guardian data, we now know that about 1 in 800 babies is screening positive. This is a picture of one of our little guys getting an EKG after the diagnosis or after the screening genetic testing. In his particular case, he had a clearly prolonged QT interval of 509 milliseconds. And in this particular case, we've now screened over 24 individuals with long QT syndrome. In this, one of the good things is that the EKG provides a very quantitative risk assessment. So it's not just simply plus minus, but the length of the QT interval can tell us how great the risk is. For all the children, we're avoiding medications that further prolong the QT interval. And for those that have a significantly prolonged QT interval, we're starting beta blockers and have done so on 5 of the children. In addition, because this condition can be inherited in an autosomal dominant manner, we've now identified several parents and other siblings that also have the genetic predisposition and prolonged QT intervals on their EKG, and in some cases, symptoms. And so several of those extended family members have now also started treatment. Finally, for an example from the group 2 conditions associated with epilepsy, this is a little baby girl who was diagnosed with Rett-like syndrome due to her CDKL5 mutation. Almost exactly coincident with this genetic diagnosis, she had her first grand mal seizure. And with this, the information, having it on hand, was very helpful to be able to start the correct anti-epileptic medication as well as starting early intervention. Within this, we continue to follow to see how children and parents are doing. We look acutely 30 days after we've given the results, as well as every year on their birthday, to understand what that process has been and continuously learn to be able to improve the process for families. As we do this, we also follow in the electronic health record and talk with the pediatricians and the specialists to get their perspective and understand how we can improve as we support everyone through this process. We ask parents how well they understand the information and whether the results are positive or negative, group one or group two. The majority of families really understand the information well, but we do always slice and dice the information in many different ways to see is there any particular subset where we can improve. And we've realized that for families that speak primarily Mandarin or Cantonese, we need to continue to reinforce the message. And so we are using our pediatricians, their pediatricians, to help do that even more. We look at a measure of a standardized outcome called decision regret to understand whether or not, again, parents have any negative feelings. We also measure positive feelings, and there are many positive feelings. A score less than 25 is not concerning to me. And you can see on the left, this is, I should say, a month after, so acutely after we give results. Overall, there are no regrets overall for either screen positive or screen negative, but we always look to see is there any particular subgroup that might have concerns, and within group two in particular, those conditions associated with epilepsy, acutely, again, a month after, there are some concerns as we follow these individuals over time to their first birthday. However, and you can see this with the royal blue on the right, that group two group of conditions, when you look over time, their decision regret comes down significantly and is now just at the level where it's barely concerning. And so for me, what I've understood as we've talked with those family members is that there's some period of adjustment. And I'll say that's actually true whenever we give these diagnoses, whether it's from newborn screening, whether it's after we give them their diagnosis, even after a child's been symptomatic, there's always some period of adjustment. As we do this, one of the things we've heard from families is that as they plug into the patient advocacy groups, the patient support groups for these rare diseases, they've realized what a blessing it was to be able to have this information pre-symptomatically and avoid the diagnostic journey that's oftentimes been many years to even decades for other families to receive these diagnoses. And with this, they've received the support from the other families in learning how to navigate and support their children, tips and tricks, how to be able to access early intervention, and they found that quite useful. So let me wrap up by saying that we're not finished in understanding everything we need to before we can think about implementing this from a public health point of view. But we've realized a way to make sure that we equitably and include all children and leave no one behind. We do realize that we need to support patients and families during this journey, and we're learning to be able to do it very broadly and do it with experts, subject matter experts, really from around the world to be able to ensure that we're making good decisions and where we need to make some very significant treatment plans to be able to be confident that the children really are going to be symptomatic and to access the care they need. If you'd like to read more about this, this was last year one of JAMA's top 10 papers of the year, but you can read more about the Guardian experience with the first 4,000 babies that we screened, and I'm sure there's going to be much more to come. As I said, we're anxious to make sure that we can get care anywhere to children anywhere, including in Ecuador and parts of Latin America. And we're learning how to do this, as I said, with various different support packets of information, clinical care guidelines, patient advocacy groups, but thinking about how to partner with local pediatricians and specialists who are right beside the patient with experts that we can bring in or their expertise through various different channels. So with this, I hope this also in the future will, I hope, open the imagination to those who are thinking about treatments and providing care, being able to have standards of care across these rare diseases and make sure that we're able to access that information to children everywhere. If you do have any questions, our study website is guardianstudy@cumc.columbia.edu, or if you'd like to be able to nominate any more conditions on our study website, you'll see all the conditions we include at any one time. And if there's anything you'd like to learn more about or nominate a condition that's not already there, please feel free to reach out. And finally, just to thank the many people who actually do the hard work to make this possible. It takes a large team, and I'm glad to be able to share it with you today. Thank you.